Hi class, let's continue our discussion of diseases of the circulatory system with endocarditis. The term endo means in, carditis refers to the heart or cardiovascular organ, and then itis means inflammation. So endocarditis is an inflammation of the inside of the heart, or the inner lining of our heart, also known as the endocardium. This is typically going to be manifesting itself within the valves of the heart. We have our left-right AV valves, and then the pulmonary semilunar, and then the aortic semilunar valves as well. Mitral valve is kind of an archaic term that's still occasionally used. We'll have a couple variations of endocarditis. So we have the bad one and the not as bad one, the acute and subacute versions. If a patient has a prosthetic valve surgically implanted, this gives them increased risk of developing endocarditis. That prosthetic valve is commonly going to have a bacterial biofilm develop on it. These prosthetic valves are sites of potential infection, and oftentimes during the surgical procedure, there are going to be new bacteria introduced during that process. It's almost impossible to have a completely aseptic environment for a surgical procedure. When we look at a healthy valve of the heart, it's going to be nice and thin, lean, and flexible. But an infected valve that has a biofilm form on it is going to have these vegetations, or this thick film of multiple bacterial species growing on it. This infected valve is going to be a symptom or associated with endocarditis. Some of the signs and symptoms of both acute and subacute endocarditis are going to be very similar to each other. They can include the fever, the fatigue, the joint pain. There's going to be just lots of abnormal circulatory issues such as edema or swelling in the feet, legs, and abdomen. There's going to be some irregular heartbeats or heart murmurs associated with it, particularly if it's going to be a vegetative growth on that heart valve. Eventually, these symptoms can ultimately lead to a myocardial infarction or heart attack. If we look at subacute endocarditis in particular, the symptoms develop very slowly and are not quite as pronounced. With the acute endocarditis, the symptoms have a more rapid onset and are much more pronounced. Abdominal or side pain is occasionally reported, and the patient, generally speaking, is going to look pretty ill if they have endocarditis. If their heart isn't functioning properly, everything else in the body is not going to function as properly because everything else in the body won't get appropriate oxygen and nutrients. There occasionally will be a petechiae over the upper half of the body and underneath the fingernails as well. Some other specific signs and symptoms can include Janeway lesions. These are Osler's nodes. Janeway lesions are red spots on the palms and the soles. And if we look at Osler's nodes, those are going to be very painful nodules that occur on the fingers and the toes. Some subacute cases of endocarditis have been associated with an enlargement of the spleen or clubbed fingers or toes due to that lack of oxygen in the blood. To give you an idea of what Osler's nodes and Janeway lesions look like, the Osler node is going to be a smaller, more pronounced patch on the digits that's painful, and the Janeway lesion is on the palm of the hand or the sole of the foot and is not painful. Most often, acute endocarditis is going to result in the bloodstream being overwhelmed with bacteria. As the infection on the inner lining of the heart progresses, bacteria will be shed into the bloodstream. Some bacteria are going to have the ability to colonize those heart valves. These are going to be vegetative bacteria, or these vegetations or biofilms build up on the valve and make that heart valve not function appropriately. As that valve is not functioning appropriately, we'll have blood flowing backwards through the heart, leading to impaired circulation. Sometimes these bacterial vegetations can break off, and as they break off, they can form emboli or thrombi in the cardiovascular system. These can also lead to further circulatory issues in the patient, occasionally leading to a blockage of a vital organ and death of the tissue in that organ. Some of our bacterial colonies are going to prove or provide a constant source of blood-borne bacteria, and since these colonies or vegetations are in a biofilm, they are very resistant to antibiotic treatment. Some specific agents that cause acute endocarditis are typically going to involve Staphylococcus aureus or Staph aureus. Less commonly, we'll have Streptococcus pyogenes or Streptococcus pneumoniae, but Staphylococcus aureus is the most common cause of acute endocarditis. Neisseria gonorrhoeae can occasionally also do it, but it's not as common. Typically, transmission of endocarditis or these bacteria is going to be peritoneal. There's going to be direct entry into the body. We can have an intravenous or subcutaneous entry point for if we have a drug user. This population or demographic is a growing risk category right now for developing acute endocarditis. If we have any kind of traumatic injury that opens up the bloodstream or any kind of a surgical procedure, this can also introduce quite a large number of bacteria into the bloodstream, eventually causing acute endocarditis. Typically, we're always going to have some kind of damage to the heart valve or some kind of congenital malformation that results in subacute endocarditis. Subacute endocarditis, again, doesn't have as pronounced of symptoms, and the symptoms take a longer time to manifest themselves. These irregularities within the heart valves are going to encourage attachment of bacteria. These irregularities cause irregular blood flow, and as we have these turbulent eddies forming, or these areas within the valves that have high velocity blood and low velocity blood, it's easy for the bacteria to attach at those low velocity points on the heart valves. These vegetative growths on the heart valves, just like with acute endocarditis, with subacute endocarditis, are also going to provide an ongoing source of bacteria for the bloodstream. Individuals that have rheumatic fever are going to have damage to their heart valves and are going to be particularly susceptible to subacute endocarditis. If we look at subacute endocarditis, unlike the acute version, which is going to be caused primarily by Staphylococcus aureus, the subacute version is going to typically be caused by bacteria in the oral cavity or that enter the bloodstream from the mouth. Alpha hemolytic streptococci, such as Streptococcus sanguinis, Streptococcus oralis, and Streptococcus mutans, are going to be commonly associated with subacute endocarditis because these are the forms of bacteria that are commonly found in the oral cavity, particularly Streptococcus oralis. Sometimes the normal biota from the skin will make it into the bloodstream as valve and colonize the abnormal valves of the heart and also lead to subacute endocarditis. This source of bacteria from the mouth leading to subacute endocarditis has led to a lot of interesting research about oral hygiene and the correlation between oral health and the development of subacute endocarditis. If we have any minor disruptions of the skin or mucous membranes, we will allow bacteria to enter the bloodstream. This is going to be caused by rigorous brushing, sometimes invasive dental procedures, or a minor cut or laceration. If a patient has an artificial valve or transplant in the heart, they are going to, generally speaking, take a high dose of prophylactic antibiotics before they receive any dental procedures just to help minimize the chances of bacteria entering the bloodstream and causing those vegetative growths on the heart. We typically are not going to have bacteria transmitted from another person to the bloodstream, causing subacute endocarditis, or from the environment. Generally speaking, the bacteria that causes subacute endocarditis goes from the surface of the patient to the bloodstream of the patient. So we can have that prophylactic antibiotic therapy in advance of any surgical procedure, or patients that are at increased risk before they receive any dental procedures to help prevent subacute endocarditis from forming. Septicemia is a condition where we have microorganisms rapidly multiplying within the bloodstream, particularly bacterial organisms. We can have many different bacteria and viruses causing septicemia at the same time. Any patient that has these microorganisms rapidly multiplying within the bloodstream is going to be called a septic patient. Septic is an abbreviated term referring to septicemia. In many cases, fever is going to be the most notable symptom of septicemia. There's going to be an elevated body temperature for those patients. The patient, generally speaking, is going to be really ill if they have bacteria rapidly multiplying in their bloodstream and spreading to all the systems of their body. This high fever and illness can also result in confusion or delirium, gastrointestinal symptoms, shakes, chills, and a wide variety of unpleasant symptoms in the patient. A lot of times the patient is going to have an increased respiratory rate. This increased respiratory rate is going to cause respiratory alkalosis as the concentration of carbon dioxide in their blood is abnormally lowered. And we'll also have low blood pressure. Low blood pressure is a hallmark of the condition because there's an out of control inflammatory response. One of the symptoms of the inflammatory response is for the blood vessels to become vasodilated and extra leaky. And these vasodilated, extra leaky blood vessels are going to go hand in hand with the blood pressure plummeting. This is the most dangerous feature associated with septicemia and is the most common cause or direct cause of death when a patient has septicemia. The vast majority of septicemia is going to be caused by bacteria, particularly if we look at the breakdown of bacteria, it's going to be a 50-50 split, generally speaking, between gram-positive and gram-negative bacterium. MRSA is a very common bacterium associated with septicemia. 10% of all cases of septicemia are fungal in origin, particularly related to Candidus. And then we could also have a polymicrobial bloodstream infection. So we could have a fungal, a bacterial combination. We could have multiple species of bacteria, or we could have bacteria and or viruses and or fungi all working in conjunction with each other, leading to septicemia. Generally speaking, these polymicrobial infections are being increasingly identified. Beforehand, as it was typically associated with one specific bacterium or one specific fungi, but as the diagnostic techniques have been improving, we've been able to identify multiple species in an increasing number of infections. If we look at gram-negative bacteria, those gram-negative bacteria are going to be associated with releasing lots of endotoxins into the bloodstream. As these endotoxins enter the bloodstream from the gram-negative bacterium, that stimulates the inflammatory response. This inflammatory response is going to cause a drop in the blood pressure and cause endotoxic shock. As we have lots and lots of gram-negative bacteria in the body, those gram-negative bacteria will oftentimes cause the blood pressure to plummet. If we look at our gram-positive bacteria, they can cause a similar chain of events to occur, but this is going to occur as the gram-positive bacterium are destroyed in our body and release fragments of their cell wall into the bloodstream. But in either situation, either gram-positive or gram-negative bacteria will cause a buildup of the inflammatory response and a drop in blood pressure. They just do it two different ways. Septicemia can be traced to a peritoneal induction of microorganisms. So those microorganisms can be entering the bloodstream directly. This can be done through an intravenous line or through a surgical procedure. Sometimes these infections can come from another source, like a UTI, urinary tract infection, or a kidney infection, or a pancreatic, prostatic, or gallbladder abscess. So a disease or an infection at a different point in the body can lead to an infection in the bloodstream. Excuse me. Oftentimes, individuals that have a spleen malfunction are going to be predisposed to a multiplication of microbes in the bloodstream. Our spleen is an organ that helps to recycle and process broken down red blood cells. And the spleen has a particularly important function in that the spleen helps to remove excess iron from the blood plasma. And if the spleen is not removing that excess iron from the blood plasma, it's easier for microbes to grow in the blood because of the increased concentration of available iron. Individuals that also have meningitis or pneumonia also are at a predisposition for developing sepsis as well. There's approximately 500,000 cases a year in the United States, And of those 500,000 cases of sepsis, we're looking at about 100,000 deaths in the United States. So there's a 20% fatality rate associated with septicemia in the United States. Septicemia is a big deal. To culture and diagnose septicemia, we're going to look at the bacterial and microorganism count of the bloodstream. Generally speaking, the blood is supposed to be sterile or free of microorganisms. So if we can culture blood from the blood, or microorganisms from the bloodstream, we can very easily diagnose the condition septicemia. The media that's used should be a blood-based medium to help culture these microorganisms. Antibiotic susceptibilities of these microorganisms should also be assessed as well. So we could do a Kirby-Bauer test on a blood agar plate to both culture the microorganisms and test the microorganisms' resistance to particular antibiotics, all at the same time. This empiric therapy should be started immediately before the culture and susceptibility results are available. So generally speaking, there'll be a broad spectrum antibiotic given immediately. And then after the susceptibility results come in, more targeted therapies can be administered. We're also going to adjust our therapies based off of the results of that Kirby-Bauer assay. So, concept check class. Septicemia is a condition where A, only one bacterial species infects the blood, B, more than one bacterial species infects the blood, C, treatment is always antibiotics, D, there is a fungal infection of the blood, or E, multiple or single species of bacteria and or fungi can infect the blood. You can rewind the video, check your notes, or check the textbook to get me an answer. Go ahead and pause it and get me that answer right now. 1, 2, 3, 4, 5. The correct answer is E, multiple or single species of bacteria and or fungi can infect the blood. An increasing number of septicemic infections are found to be polymicrobial in nature and involving more than one species of bacteria and or fungi. If you have any questions for me about this material, please post them in the class discussion board or shoot me an email. Happy studies.